Today's presentation is sponsored by NATROX, and I'll actually, I'm going to start with a story because I'm talking to Craig Kennedy, and one of my partners says, "Tom, what are you doing? Topical oxygen? Are you serious?" You know, it's for those who don't know me, I run a wound and hyperbaric company, and I own 44 hyperbaric chambers. So my partner looks at me and says, is this a good idea or not? So I hope I can convince you when we talk about this clinical trial that it was indeed a good idea. Again, sponsored by Intertech, and we want to thank them for breakfast. I also want to thank them for this journey that we went on, and it was really a journey. We're going to talk a little bit about CMS in a bit, but CMS really forced us into doing this trial in some very unique ways and very fast. We had to enroll over 125 patients, and we ended up enrolling 145 in total. But we had to enroll 125, and we did it in 5 months, which was breakneck speed. For those who've done clinical trials, you'll know that it's almost impossible to keep up with that sort of pace. So it was a really interesting journey, and I hope that you enjoy the journey as well. So what we're going to talk about is diffusion of oxygen into the wound, and you have an oxygen generator, and it delivers a humidified oxygen into the wound by hydrolyzing water. So it's a fairly simple device. It has a battery, and then it will deliver oxygen, and you can wear it. It's very portable, which is there's some really nice features about it, but this is the basics. But let me go now into saying why topical oxygen? Let me go back and answer my partner who said, "What are you doing?" So there are at least 3 mechanisms, and I'd say there's more than this, for how topical oxygen works in chronic wounds. There's an antimicrobial effect, there's an increase in energy production, and then we have known for years that oxygen promotes epithelialization, and we'll walk through each one of these. I'm going to go quickly through the antimicrobial because Karen's going to talk about more specifically about, and she knows way more about bacteria than I do. So I don't want to be embarrassed. So we'll go through it quickly, but oxygen is important for leukocytes, particularly neutrophils, which kill with an oxygen burst. So they concentrate oxygen, and then they release oxygen. That's how they kill bacteria, by ripping off an electron, making a free oxygen radical, and destroying the bacteria in that fashion. So if you have a low level of oxygen in your wound, your neutrophils are not going to kill effectively. So our initial innate immune response is highly oxygen dependent. And this has been studied in animals over and over again. There are literally hundreds of studies demonstrating that you get a better immune reaction at the higher the concentration of oxygen in the wound. So I didn't mention, but it's also important that you do get a bump, but this has been well studied. You do get an increase in oxygen tension in the wound when you apply a topical oxygen device. So when we look at this, this is, again, bacteria, and this, Karen's going to talk more about this. I'm not going to talk too much about it, just to say that wounds go from this acute wound to a chronic wound, and the microbiome changes it. And I think what we'll hear later is how topical oxygen can change the microbiome. And again, she's going to show this. This is just, I think that's from you. I think I stole that from you. Yeah. So I stole this from Karen. So she's going to talk. I'll let her talk about that. All right. So the second mechanism for topical oxygen is energy production. Now, I'm not a mitochondriologist, if there is such a thing. Anyway, but mitochondria is super interesting organelles in the cell, and they are the energy producers. Interesting thing about mitochondria is it generates the energy to convert glucose into energy, ATP, by pumping hydrogen ions across the membrane. And that's done by a molecule called cytochrome C oxidase, which is a super interesting molecule. We had a day up at Wellman in Boston. It was just, the whole day was on cytochrome C oxidase. It was a long day, but it's oxygen. This is an oxygen dependent molecule. So the more oxygen you provide the mitochondria, the more ATP you produce. And this has been done. This is one of a rat study just showing in a low oxygen environment, you produce in this case, there was 2 ATP or 2 molecules of energy, but in normoxic, you get 36. And as you increase this oxygen tension to a plateau level, you continue to get increased ATP or increased energy. And this is one of the second mechanism by which topical oxygen has a cellular support. The third is something we've known for a very long time, and that is that epithelial cells, keratinocytes, love oxygen. I remember T.K. Hunt here in San Francisco many years ago talking about that giving epithelial cells oxygen was like putting lighter fluid on your charcoal fire. They really respond very well to it. And there's been a number of animal and human studies. We have a number of case studies where what this venous leg ulcer needs is epithelialization, and we can promote that by adding oxygen. And this is a patient with a diabetic foot ulcer, and I was testing TK's theory and adding oxygen along with just basic wound care, and the patient went on to heal very rapidly with the addition of oxygen therapy. And this is all before the upcoming clinical trial. So there's one missing here. I didn't put Bob Freiberg's paper on this slide. These are more continuous diffusion oxygen, but actually the AOD trial should also be on here. There's a number of trials that were pretty well done. There's 300 patients in these trials. This demonstrates that we have a lot of evidence for topical oxygen. CMS doesn't think so. So CMS has not agreed to reimburse this in a national way, and they looked at these trials, and they had a lot of criticisms, a page full of criticisms. You didn't have a run-in period. And I remember most distinctly, the other complaint they had is, you did all these trials and none of them were our patients. You didn't trial that on our patients. You've got these diabetic foot ulcer trials and they're not Medicare beneficiaries. So if you want to do a trial and get us to pay for something, you got to have our beneficiaries have got to be in the trial. So we're taking notes. Okay, half the patients got to be over 65. We're going to make sure we have a run-in period. It's got to meet the NCD. Now, in the US, if you want to get approval from Medicare to pay for a product, you have to do 4 weeks of standard wound care, and the wound can't have healed by, we say 40% for diabetic foot ulcers, some say 50, over that 4-week time frame. And if it doesn't heal by that amount, then that patient needs advanced wound care. Well, Medicare went back and looked at those trials and said, none of those trials did that. They also said you need to have 3 digits in your trial. And we need 3 digits, at least 100 patients. So we got a lot of feedback based on those trials. And these are well done. Particularly the top one there, they're very well done clinical trials. And we really thought, honestly, that we would get approval based on this. No, that's not what they said no. So we embarked on the trial that I'd like to share with you today. So everybody had a 4-week run-in period. 2 weeks was historical. We looked at the patients and said, during that 2 weeks, before you get enrolled, you cannot have healed by more than 20%. And then we put them in the trial and gave them standard of care. And Medicare actually gave us a compliment later on after we finished this trial. It said they called it super standard of care. Aggressively debrided. Offloading was total contact casts. So we did the gold standard. How many diabetic foot ulcer trials have you seen where TCC is the standard of care? Because it is the standard of care. And then we did a reduction of bacterial burden, very aggressive. And then half the patients we enrolled, and I'll show you the data in a minute, were going to be over 65. So we stratified for that. And then we randomized patients to topical oxygen plus standard of care or standard of care alone. We had 19 clinical sites across the United States, well represented geographically, and we were off. All right. So a little bit about the run-in period. So I really mentioned this already, but the inclusion criteria, everybody had to have 4 weeks where they hadn't healed by 40%. So, during the last 2 weeks of that, they had to have a total contact cast. Now I'll tell you something. What was our #1 screen failure? We had a lot of screen failures. I'll show you in a minute. Our #1 screen failure, they healed too much. But we were getting rid of the rapid healers. And that's what we want to do. And that's what Medicare want to do. Medicare says, if you can get them healed by that much in 4 weeks, they don't need to be in your trial because we're not going to approve that as a modality once we approve your product. We're not going to these are your patients. These are the ones that we're going to treat. So, okay, that we did. And I can tell you story after story of patients who had, 6 months of treatment at places you would recognize the names. And then we can't get this patient healed, and we're going to refer him to you for this clinical trial. We put him in the clinical trial, aggressively debride him, put him in a cast, put him in a good dressing, and come back next week, and they healed by 50%. We had people healing in the 2 weeks. We had a lot of people heal in that 4 weeks that were had been open for months. So that actually, as you can see, is going to be our #1 reason for screen failure. And I'm going to give kudos again. This is a sponsored breakfast, so I can say that to the folks at, and Kathy and I were just talking about the weekly calls we had, and they were very patient with us because we had a lot of screen fails. And you have to have a very patient sponsor when you have a lot of screen fails. Like, what are you doing? But it was important. We used, this is pretty much standard now in the clinical trials. We used our 3D assessments. We used, and I'm going to throw another name out, apologize for using trade name, but tissue analytics, where we were able to take the photos. The neat thing about it is that all the monitoring for this trial was done primarily remotely. So this is really a remote trial. And another thing, one of the great things about having fun with trials is we had enrolled about 125 patients, right around there. And then there was this thing called coronavirus, you may have heard of it, that shut the country down in the middle of our trial. So we actually took a pause, and then because wound care is essential, we were able to restart our clinical trial, and we actually enrolled 18 more patients during the pandemic. And it's not in this presentation, but we are now going back and looking at the difference in healing between in the pandemic and out of the pandemic, because the results are different. All right. So baseline characteristics, there was no statistical significance between how long they'd had the ulcer, between their age, their ISDA grade for infection, or their Wagner grade at all. There was both groups had equal representation. Roughly 55% of the patients were over the age of 65. So we had met that criteria for Medicare. In fact, it's funny. It's the first one I've ever done, the first trial I've ever done where I had made this a criteria. And it presents its own challenges. And we can, over a beer sometime, we can talk about putting total contact casts on 80-year-olds. There's some real challenges that I had not foreseen. All right, so this is our consort diagram. There were 224 eligible for enrollment. And then we excluded, you can see that we excluded quite 29 on initial, and then 50 were excluded because of later on, before they got enrolled. And what you want to look at is this right here, where it says wound reduced by greater than 20% during that run-in, 34 patients. So there's a very large number of patients were excluded. We randomized 145 patients, and then we followed them. Now, one of the things you're going to see here, we're going to go to the results in a minute. One of the things you're going to see is that the standard of care arm seems like the healing rate's really low. It is, and that's the way it should be in modern diabetic clinical trials. Because if you're doing all this in the beginning, you're going to take all your fast healers out. So rather than most of our clinical trials before this, we expect the placebo group or the standard of care group is going to heal 40 to 50%, rough in that range. So that's not going to happen here, and you'll see it's going to be in the 20s. And I can tell you that we have trials where it's below 20, and that's because we've selected out the patients who need advanced wound care. These patients will have a hell of a time healing unless they get something that is advanced. All right. So looking at complete healing, look at the top, which is intent to treat. And I'm really super proud of this, but we met not only the per protocol, which we'll talk about in a minute, but the intent to treat. Now go back and look at some of the clinical trials that have been done in diabetic foot ulcers. And, heck, I think I did probably half of those. And you don't meet intent to treat very often. And the reason that's really kind of interesting is because if the patient had at least, I think it was 6 weeks of oxygen therapy, they were counted. So if they had 6 weeks and they dropped out, or they had 6 weeks of oxygen, and they tore their dressing apart or whatever, and they didn't, they still counted. So it's really hard because a lot of those intent to treat patients didn't get a full course of therapy. And that's one of the downsides of intent to treat. So this was really a extremely positive finding. And of course, in the per protocol, where the patients did receive a full course of oxygen therapy, then they healed. There was a much more significant healing, and about twice as many patients with topical oxygen healed over those who just got standard of care alone. And you can see, look at the standard of care arm healing, it's very low. And that's, I think in modern diabetic foot ulcer clinical trial, this is where they should be. Because if that number's higher, that means you didn't pick patients we didn't pick patients that needed advanced wound care. All right. So just looking at the per protocol group now, we had 52% healed completely compared to standard of care. We had a 71% greater healing rate, and on average, the percent error reduction was much better in the topical oxygen. They healed faster, sooner. So in other words, what happens is first you get this exudative response when you use the topical oxygen. It kind of drains a lot for the first couple of weeks, and then it starts healing like gangbusters. And that was kind of the course that we saw. All right. So percent error reduction. We also, as we looked across the trial, we saw that we had a greater reduction in the way the wound sizes as we went from week to week to week. And you can see that that's also statistically significant. Why did I include this? Because we're doing a lot of work now with FDA and CMS, and we're trying to get these as endpoints, right? Percent error reduction is hopefully going to be an endpoint. So if you make a debriding product, are you going to study you're going to do 12 weeks? No, you're not. I mean, or if you're making a topical antimicrobial, you don't want to use it for 12 weeks. So we need to have this so all of our trials look at percent error reduction, but it's with topical oxygen, you can see that almost every time point we had more rapid healing in the oxygen group. All right, just a couple cases. This was one of mine, and this was a patient that healed in like 4 weeks. Again, what happened here is I debrided it. We put the oxygen on. I called Kathy. This thing's draining like crazy. So, she said, "Don't worry, that's what happens." So, and she was right. And then within a few weeks later, we had complete closure. And similarly, that's one of Matt Sabo's patients over on the other side. But we had some real rapid healers too. It's interesting, and you see this in a lot of diabetic trials where the standard of care arm heals about 10 weeks or 11 weeks, but you don't have 4 and 6 week healer in the standard of care arm in almost any clinical trial. But if you have a product that is effective, efficacious, you get some of these really fast healers, and these are fun, right? These are really what makes clinical trials a lot of fun to do. All right. So then we did a long-term study. We followed all these patients for a year. And I have to show Dr. Al-Jaladi's picture. He was our NATROX fellow. NATROX supported his fellowship with us in wound care. He's going off to do a surgical residency now. But he had the job of, during the pandemic, chasing all the patients and trying to find them. And he spent a lot of time. It was a lot of time. And, we had a couple patients die of COVID, unfortunately. And, but it really was a chore and difficult to track all of those patients down. But what we see is that 78% of the NATROX wounds remained healed at 1 year, and 60% of the standard of care were healed at 1 year. So we had a little bit greater durability if you got topical oxygen as opposed to just getting standard of care. Now, we're just in the midst of publishing this. We didn't have enough patients, and we lost too many to really get a good statistically significant difference. But I got to tell you that for chasing patients down in the middle of a pandemic, Dr. Jaladi did a really, really great job, and I'm glad he'll be first author on that paper. All right, so we had a conference in May of this year. It was a lot of fun. It was good. It was fun to get together last night. It was fun to get together back then. And what we did is a Delphi Consensus based on the use of topical oxygen. And this is our Delphi group, and I want to thank them very much for participating. We got it. I don't know if you know how Delphi works. You do a survey for people that are experts in the field, and then they have to get to agreement. And then you just keep sending the survey out until everybody agrees or disagrees. And you have to get 70% in order to say that's statistically significant and proceed with the Delphi. So the workup for topical oxygen, that everyone agreed on was, everybody said they should have limb perfusion, ABI, TBI, NEARS, whatever you're doing, that should be done first. We should look at bacterial load, nutritional assessment, debridement, edema management, offloading. Those are pretty basic, and that was there's a few other things I would add that, but the group could not reach consensus on. When should you consider using topical oxygen? Delayed wound healing, everybody said that. So if you have a wound that you're treating, it's not healing, most people said after 4 weeks, then you should consider adding topical oxygen. Failure of prior therapies and ischemic ulcers. There were more than a dozen vascular surgeons on this Delphi, and we had a lot of I get a lot of nasty notes. They're allowed to write comments on a Delphi, right? So, anyway, I won't share their names, but they send me a lot of things. Well, so we finally, after going back and forth many times, we were able to get a consensus of 88% that should be. I personally like to use it on topical oxygen for ischemic wounds, but that's not everybody agrees with that. Although we were able to reach consensus. The wounds most likely to benefit: diabetic. That's where all the evidence is. We've used it for venous. I think there's another area where it may be very beneficial, and then ischemic ulcers as well. Frequency and duration. Patients with topical oxygen should be seen at least weekly in the wound clinic, and that just barely made consensus, and a lot of disagreement. Some people wanted to see them twice a week. I'm saying, no, I don't have room to see them twice a week. And then others were saying every other week, and particularly as this is a pandemic still, so people were saying, well, I'm not going to see them every week in my wound clinic. But everybody finally agreed to once a week. And then how long? Reassess the wound every 4 weeks to make sure that you're healing, and continue topical oxygen as long as the wound is improving. Some people said use topical oxygen until you can apply a CTP or other product, but I will tell you, we did not reach consensus on that. So that was, there was 5 more things down here we didn't reach consensus on. And so we didn't have a lot of people that wanted to use combination therapy yet. All right. So this is from the paper, just goes through our algorithm on how to use it. And it pretty much goes where I said, you have a wound that hasn't healed by 40% in 4 weeks, or refractory to other therapies. You can assess the wound as we described, and then apply topical oxygen, reassess in 4 weeks, and then continue until the wound's healed if you're getting a response. There's quite a bit of evidence for oxygen therapy. 6,000 publications on oxygen in the world literature, and topical oxygen has at least it has a number of RCTs, and I think there's actually 7 total. Although I will tell you that in our meta-analysis, which we're in the process of just completing now, we only had 3 that met criteria, and that was Bob Freiberg's, and then Dave Armstrong and his group did another one, and then our group did the 3rd one. And this is ongoing now. This is being led by Dr. Marissa Carter. We have that much evidence, you can put it all together in a meta-analysis. Anyone ever done a meta-analysis before? They're not fun. No, they're not fun at all. And it took us about 6 months. We're about 6 months in. You have to do that literature search, then you have to go through the grade criterion, then you have to do that bias thing that I got wrong every time. Anyway, but thank God we had smarter people than me on the meta-analysis, and we were able to proceed. So this goes back to where I started, and that was this myth that that topical oxygen and hyperbaric are competitive in some fashion. I don't see that. First of all, hyperbaric oxygen is not going to be readily available everywhere. Even though you see a lot of, Naz and I were talking about Las Vegas, how many you got a lot of hyperbaric chambers in Las Vegas, but that's not true in Albuquerque. So there are going to be areas where we're just not going to have the setup for hyperbaric oxygen therapy. Also, if you look at those trials in diabetic foot ulcers, those are Wagner 1 and Wagner 2s. Hyperbaric not indicated for those, indicated for Wagner 3s, and it's a totally different mechanism of action. We don't know how complementary they are. It is possible that we could be using them together or in some sort of combination sequence. Those of you who know me know that I love combination therapies. I'm jealous of our oncology colleagues who do. When I first started, my first research I ever did was oncology, and they hand you a book of approved protocols, And they're all different combinations of mostly chemotherapeutic agents. And they just go back and I think this is great. And I got into wound care and we only test one thing at a time. We rarely put things together. That's something we've got to change. I'll get off that. The mechanism of action, why you choose topical over hyperbaric, I think it's completely different. Topical oxygen, I choose it for our antimicrobial effects, and hyperbaric oxygen more for the stem cell effect in more serious wounds. All right, so we're going to switch computers. And while we're doing that, I'll ask if, I'll give you my email, but I'll ask if anyone has any questions or comments, additions to the trial design. Yes.
Curious to know that in your selected group in the trial, the ones that heal fast, so the ultra fast healers and then just the faster healers. Can you figure out what that nuance was? What was the difference between a shitty wound over on this guy and a shitty wound and then went quick on that? Is it you're attributing solely to the oxygen?
Well, no, we're looking at it. Exactly. We're actually one of a couple of our research analysts now are actually looking at that. We're going and looking at all those. We've picked out all those fast healers. And now we're going back to see if there's something we can find some reason, whether it was the clinical trial site, that could be a possibility, or something else. I mean, the care was really standardized. I mean, everybody got CAS, everybody got debrided. We checked the debridement, so you took a picture when you got enrolled, and that picture was sent to one of us. And we looked at it and said, we had to agree there was that had been adequately debrided. So we had really, so it was, we were terrible, really surprised by that rapid healing. You're saying, why? And I mean, you have to think most of it's topical oxygen for sure. But why did those particular patients respond so wonderfully to topical oxygen? So that's something we're looking at now. That's a great question, because we're going back now that we published the main body of evidence. Now we don't want you with a big, got 145 patients, and I got 145 patients worth of data. And now we're kind of going back and sifting through it and seeing, okay, how long did they stay healed? And then, what about these rapid healers? What about the ones that didn't respond? Same thing. Was there a reason that we didn't see a response in some of those patients? Maybe this.
Okay, thanks for the opportunity to present at breakfast. Some people don't know me, so I'm going to do a brief introduction, and I'm here to talk to you a little bit about the basic science around topical oxygen therapy. As a background, I work in Toronto, so I'm a plastic surgeon in Toronto, but I'm also the first in Canada surgeon scientist entrepreneur. So I've been hired by the university system I guess as a knowledge translator, so to bring things from bench to bedside. I work in one of the largest health organizations in Canada. We have the largest wound care group in Canada as a multidisciplinary group. And my organization at the University of Toronto is one of the largest research organizations in North America. So just to give you a sense of where I work. The hospital itself, so where we work, we're a level 1 trauma center. So we see everything from open abdomens, gunshot wounds, really actually some crazy, very large wounds. But we also have one of the largest diabetic lower extremity salvage or preservation centers. So my team really is a multi-D team, so allied health professionals, as well as vascular surgeons, orthopedic surgeons, internal medicine, infectious disease, and we all work together to try to help the patient. And we see thousands of patients a year, so not just with diabetic feet, but with wounds in general. I have a little bit of bronchitis, so I apologize for my scratchy voice. I'm clearly not going through puberty, a little older. I've been a proponent of oxygen. I've been studying oxygen for over 20 years. Oxygen for me is the vital product that you need in a wound in order to heal it. And in fact, when topical oxygen became available 10 years ago in Canada, I was one of the first people to adopt and sort of try to figure out, why does this work? And that's really what this talk is about today. Overall, for me, the advantages of topical oxygen, so just as a person who's used this quite frequently and for a long time, I like it because the delivery is 24 hours a day. You don't have to do any additional dressing changes, which in a country like Canada, that's very big, and people have to come from far away to see you. That's great. And also means one home care visit, which our government pays for. You don't interfere with offloading. So some of other products, you might not be able to put them in a total contact cast. Definitely 100% you can TCC these patients, and we do our own custom TCCs, so even somewhat more challenging with our orthotech. I really believe it saves costs associated with those home or hospital visits, and we saw that certainly during COVID, and I think the whole world started to understand why that's important. It's easy to apply, it's small, inconspicuous, and there's no noise, and that's really important for the patient, and it helps with patient compliance, and that was a lot of feedback. They just slip it in their pocket or put it around their leg and they're fine. And then finally, it's accessible. So also, there's a concept called minimally disruptive medicine, which we practice in my clinic. We know that compliance drops when the burden of treatment is high. So most of our patients are very compliant because I find things that work within their own system and what's working for them at home. It also allows them to function normally. And so if you have a chance, this is a concept that came out of the Mayo Clinic to look at MDM, and our diabetic patients definitely experience this type of disruption. We didn't make your meta-analysis, but we did do the first RCT. But it was a powered study, but it was small. So there was 20 patients in this study. We also do a washout period. So everything we do when we're looking at oxygen, we have a washout, 4-week washout period before we enter anyone into a study. So that's a typical protocol for most wound centers. And really the idea behind it was, could these patients with non-healing DFUs over 8 weeks duration, which in Canada, generally they come at 26 weeks. So on average in Canada, your wound's open for 26 weeks before you get to a wound center. And then we did standard best practice of care, which is the same that happens in here in the United States, as well as standard best practice with NATROX. This is, I guess, the sort of an example of how we taped it. So we were a little bit innovative when we started to figure out how could we get these discs to stay. So we actually use steri-strips. So we just put little steri-strips around the edges, a foam over the top, and then get them in their TCC, wrap the tubing. Patients were well matched at baseline. So with respect to how long they had been open, as well as the total area size between control and the NATROX group. So no differences there. Also with respect to their demographics, but giving this talk very quickly. So I left some slides out. If you look at who healed or the percentage of healed chronic DFUs, and we graded them, and we use Texas grading in Canada. So I know there's UC Wagner, but we found that in those earlier grades, not really a big difference. So no difference really between the control and the NATROX group. But when you start to get into those more severe or more the deeper wounds, definitely a big difference. And we found that they healed. They all healed within these groups. So that was, I guess, it was interesting to us, but also intuitively makes sense. Texas grade 1, clearly, they will probably heal on their own with best practice and standard of care if they get it at early time points. And I do believe that the NATROX made a significant difference in the healing of twos and the 2s and the 3s. Also, we noticed that there was rapid changes, and this is the premise behind some of the biofilm work that I'm going to talk to you about, that at 2 weeks, we started to see that the wound was rapidly starting to change. And it was both in wound size, as well as the amount of exudate, as we've already talked about. The exudate, however, it's almost like the wound is dripping. And when you have the limb and they're in your chair, you can actually literally see fluid just weeping out of the wound. The dressings are actually sogged. You have to change them very frequently in the first 2 weeks. And it was my idea as a basic scientist in the beginning that this truly was about how oxygen gradients and keratinocytes were migrating based on these gradients, and fibroblasts were migrating on gradients. But when we saw this exudate, we knew that it was more than an oxygen gradient. When you see exudate like that, that's thin and clear, it usually means that the biofilm is changing. So your microbiome, your bacteria are changing. And these are the byproducts of what happens when you break apart a biofilm. And so when we saw that fluid, we knew that perhaps this was what was happening. We hypothesized that that was the case. So overall, again, all the patients healed at the end of 8 weeks, which is almost incredible if you think most of these patients were open for over 26 weeks by the time they came to see us. So just some clinical tips and pearls based on my experience. You have to do the exudate management. So just quick, if the topical oxygen is working, you're going to see the exudate. If it's dry, honestly, it's probably not working and you have to do something else first. Not for this particular talk, but we can talk about it later. You have to change the outer dressing more frequently. These wounds will get macerated. So we brought them back to change the foam. As well as with the offloading, I brought them back twice a week for TCC versus the once a week, which we would normally do. And you have to protect the skin, so it has to be cushioned, or you can get a pressure wound from the tubing. After 2 weeks or 3 weeks, your exudate is going to settle down. That was what we found in the study. You can use your dressing of choice, and you can change it every 2 days. So that's just a little bit about my clinical tips and pearls. So overall, back to thinking, okay, is NATROX or is the topical oxygen changing the wound biofilm? First thing I want to say, at least this is a very knowledgeable group, but most people talk about biofilm as something that you can see. So when you see that fibrinous debris on the wound, it's, oh, I'm debriding the biofilm. You absolutely are not debriding the biofilm. The biofilm does not live in that greenish fibrinous debris. It lives below. So once you take that top surface off, the biofilm is actually within some of that granulation tissue. You can't see it with the naked eye, and you don't know if you're taking it off or not. You have to do this with specific tests. We also know that they're very sophisticated. So they're going to attach, they're going to grow together, they're going to bring their friends, and then they're going to detach when it comes to infection, or if they're trying to change what's happening in their own microenvironment. If you look at it, what happens, and how I explain this to people, it's like a condominium, a complex that's put a big wall around itself in a spherical way. So it initially invites all of its friends into its condominium complex. It starts to give them information called intracellular signaling or quorum sensing, where it's telling them, hey, you know what, here's our virulence factor. Let me tell you how we destroyed this other cell. And so it's sharing information. And so the bacteria are very sophisticated. It also creates an alpha dog. So there's an alpha dog in the wound. So one of the bacteria will become the general of the army. And it is giving those signals to the other bacteria, telling them what to do. And then they also have what we would call the spies. And so the spies take all of that information and they keep it and they hold it. So they are almost like the vault of info, and they stick around. So they don't ever usually go away. And then they put a force field around them with the exopolymeric matrix. So this is actually much more complicated than just simply saying, oh, there's a biofilm and I must debride it. We know it's a major barrier to wound healing, and I realize we're going through quickly here, so we'll just go through this fast. The most important thing to remember is that the biofilm is hard to eradicate. So they're resistant to antibiotics, and it's mainly because of that matrix. There's multi-species, so it's not just bacteria, but it includes yeast, et cetera. And as well, there's 1% of the persister cells. So the persister cells are the spies, and the spies stick around and have their messaging. In order to treat them, you have to attack them on multiple fronts, but not all biofilms are bad. So this is the part where I want you to pay attention about the skin microbiome. If I went and I swabbed everyone here in the room, what we would find is that different areas of your body have different bacteria. So they have a different microbiome. So if your forehead, which is oily, has a different, speciation than if it's a moist, antecubital fossa, dry, and foot. So remember, every part of your body is different. And we've done this through multiple studies using PCR. So they're swabbing. Everyone knows what PCR is now because of COVID. And we do our fungi as well as our bacteria. Overall, patients with diabetes are already at a different baseline. So in diabetes, essentially, they don't have as much staphylococcus. So there's a reason for that, which we can't get in today. But in our control group, so you and I who don't have diabetes, we have a bigger population of staphylococcus. So as you can see here, what we've done with PCR has shown that people with diabetes without a wound are automatically different. So they're already behind the 8 ball when it comes to getting infections as well as healing their wounds. Again, looking to wound chronicity, topical oxygen therapy, in my opinion, should be used really at the beginning of the wound, because we want to make sure that these patients who are already at a different baseline don't change to become that chronic wound and don't change to become a different type of microbiome. And we want to keep them sort of at their baseline or back to what might be normal. So then we asked the question, what effect does NATROX have on this wound biofilm? We did a similar study, again, a washout period. In this case, what we did is in the washout period, we also took swabs for PCR. So we're profiling the bacteria at each point and each stage of their journey, as well as up to 8 weeks after in their therapeutic group. When we looked at, say, a non-responder, so someone who did not respond to NATROX, what we found is that they classically stayed anaerobic. So remember, when we do these PCR tests, we're running thousands of types of bacteria through our PCR machine, and then we profile them. So what you see here in the graph, if you can see my cursor, is that they mainly stayed orange. So orange means anaerobic. Anaerobic thing and then in the green, this is your aerobic. So this would be like Staphylococcus, Corynebacterium. This is a person who actually did not go on to respond to NATROX, but that's not why we're here. What we're here is to talk about what happens if they heal. So what happens if they respond to NATROX? So in this case, what we saw is at the beginning of week 0, we profiled their wound. They looked like a very typical diabetic, mainly with anaerobic bacteria. But as they started to use NATROX, especially around that week 2, 3, we started to see the shift in them becoming aerobic. And this is a huge, huge thing, especially in microbiology, to show that you can shift a microbiome. So I'm not telling you I cultured for one bacteria. I'm telling you these patients shifted their microbiome. And that's a really incredible thing to see because they're mainly anaerobic from the beginning. So not only did we get them from their baseline profile, we actually converted them back into something that looked more normal. So NATROX is actually helping them become more normal. And so that actually is by week 8. It's almost incredible when most studies are actually up to week 12. Change is good. And again, this is just showing over time that the microbiome is changing. If they do tend to stay in green where they are anaerobic, this is a wound that's probably not going to respond to the topical oxygen, and something else needs to change to help push that wound into an aerobic space, or it just may be that the topical oxygen is not going to work for that particular patient and something else needs to happen. In terms of the clinical impact, this is just showing you the responder versus the non-responder. And again, in green, mainly aerobic type environment is your responder. And if it mainly stays anaerobic, then it is a person who's not going to respond. And then quickly, and we don't have to go over this too much, but using non-invasive, non-contact imaging, we can do oxidant damage, that's within the foot. We looked at this also with the NATROX device. These technologies actually come from the art world, and this was a painting they thought was by Leonardo da Vinci, but the art history buffs didn't want to take the painting apart to see if he had in fact painted it, because this was also painted by Filippino Lippi, who's a very famous Italian artist. And what you can see using NIRS is below the surface is Leonardo da Vinci's painting. So the idea for taking these technologies from art and actually from space and bringing it into medicine is something that we also do in our lab. What we found here is that these devices can actually measure oxidant damage, and you sort of set that up for me in your talk. If you were a responder at week 1, we found that oxidants were detected and it was well circumscribed in the wound. So you can see that by the blue that's here within the wound. And this is just our marker, okay? So this is a reference standard for what we're looking for. By week 8, you can see our marker is showing that we have detection of oxidants, so that's the oxidant standard, but yet not much is left within that wound. So this is in a NATROX responder, and again, this is a research tool. In a non-responder, again, we see that oxidants are detected within the wound, but also in the circumference of the wound. But in that non-responder, not really seeing anything show up that continued detection of oxidants at week 8. So we know that by measuring the oxidants, and again, back to your point, that this is something where the NATROX isn't really making a move within the tissue. So it's still maybe staying anaerobic, as well as we're starting to see more damage to the tissue. So some reasons I have a lot of hypotheses around that too, but I realized that it's 7:54 and I've had to go through a basic science talk, and I'll just leave it there and we'll open it up for discussion. Or maybe I bored you all, or it's too fast. as an area where these spaces, often get flushed out, they don't really qualify for FACHM. It's not a ton of great. Yeah, so I actually agree with you, and it usually happens again around the exudate period. So just after you get through exudate, it's almost like their pain decreases, and then the wound size starts to change. Yeah, in COVID, actually, honestly, we used a lot of topical oxygen because I could walk the nurses through the changing of the dressings, and I like it actually a lot for ischemic limbs and venous stasis. It's my favorite dressing for those two clinical problems.
How do you manage that group? Like, I know that you can put dressings on, but in our world, that'd be a hard thing to really crank out. You have to have twice a day dressing, but you feel that might not work. Like, and then how much fluid are we talking about? And is that going to wreck the environment? Like, does that come up? Like, because I'm just thinking about this is great, but it's that my excitement is tempered by those 2 weeks of what we're going to do with them. We put them into a worse state with maceration that's going to be generated. So I'm just wondering what, I think how did you manage that? And what were these in-house people, or were they coming to the hospital for training?
Yeah, they were all outpatients, and we managed them with home care. So home care would do the outer dressing changes. You can get maybe 2 to 3 days out of the foam. But the total contact cast will not survive. So you definitely have to bring them back every 2 to 3 days. So yeah, we had them in total contact cast. But I double layer the foam. So I'd use something that's not sticky. I don't want to brand. In the first 2 weeks, you have to change it twice a week. Yeah. And then it settles down, and you just prepare the patient for it. They are going to be macerated, but honestly, they heal. It's not going to break down. I think you get scared, especially when you first start using it, to see so much maceration. But frankly, the peri wound survives, and it does great. Yeah. Yeah. But yeah, we are old school, so we have an ortho tech, and we use a stirrup and a plaster material. So yeah, we're old school. We don't have a prefab.
I think those are better than the sloppy there. Macerated, it might be pretty disastrous.
No, and especially we know that it's changing the microbiome. They're not infected. So if you have an infection, clearly you have to treat the infection. But if it's a regular diabetic foot wound with its microbiome in there, I don't treat them with antibiotics. We have some studies that we haven't shown or published yet, where we show even the impact of some of the antiseptics on the microbiome. And what we think we know in medicine is not actually true, as well as the impact of antibiotics. So the antibiotics actually aren't doing that much for the microbiome. So I believe in this space, at least based on my experience in basic science and clinical, that it will be topical things that will change the microbiome, because our systemic antibiotics just really treat when they flourish in one area. So for Pseudomonas or et cetera, yeah. Yeah, I was
thinking more like Pico or something like that. Pico wouldn't have the capacity to really drain a lot of it. You have that big, monster pad. I don't know if that would work.
I've not tried it, but I do like to check them more frequently in the beginning. Like, it's just good to have someone lay eyes on them, especially if you're new to the product. I mean, I don't worry about it. They just call me and I say, all right, just change the foam, you're fine. But in the beginning, I was a little bit paranoid about what was happening. And I think most people, when they start using it, are also a little bit concerned about how much fluid comes out of these wounds. Yeah, so part of the PCR would actually capture, because it's a swab base, so we don't take tissue samples. So it would come up, but I've never tested the fluid. I think they do have someone testing the fluid within. Yeah. For next year. Yeah.
Probiotics to maybe change the microbiome just a little bit to add that good bacteria to allow it to heal.
Yeah, so there are some studies that are coming out of dentistry that show you can swab the teeth and then you know what's happening in the foot. Yeah, so again, I've not done that, but I do recommend, I have a nutrition protocol. So I have a nutritionist or dietitian that I work with in my practice, and I have a nutrition background. So I'm a biochemist, but a nutritionist. So almost all my patients are on probiotics anyway, but not for the studies, clearly.
I
But
just don't know how many diabetics are really on probiotics, right? Like,
they're probably not, but we don't also understand how the gut might impact, like changing it might impact the wound, but it's for the future.
yeah.
Yeah.
I just wondered, you know, when we talk about topical, we also want to try to get it from inside as well, so that it actually works with topical, right?
Yeah.
Like,
I think what'll happen in the future, if I speculate, is that we'll be able to do some of this stuff from your mouth and then figure out, but it is not going to be a systemic antibiotic that's going to change what happens here. It's going to be topical. We have to change it in its own environment with the gut. That's good. Good conversation. Yeah, that was good.